Morning, everyone, again. Welcome to the January 24th, 2023 Licensing Committee meeting. My name is Sung Oh, Chairperson of the committee. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. This meeting is being conducted consistent with the provisions of Government Code Section 11133. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must join the WebEx meeting. Information and instructions are posted on our website. As I facilitate this meeting, I will announce when we're accepting public comment. I have advised the meeting moderator to allow 3 minutes to each individual providing comments. This approach is necessary to facilitate this meeting and ensure the committee has the opportunity to complete its necessary business. I'd like to ask staff moderator in the meeting to provide general instructions to members of the public participating via WebEx. Moderator?
This is the moderator. When public comment is requested, we're going to open the Q&A feature in WebEx, and it'll look like this. And we will have the instructions on the screen, which we will have here momentarily. And there you go. So here are the instructions. So each time the committee opens for public comment, the instructions will be on the screen for your reference, and I'll give verbal instructions. So if you are logged in, you can click the question mark inside of the squares, typically located bottom right corner of your WebEx screen. And in the text field that appears, type in the word comment and make sure it goes to all panelists before you click the send button. For those who are calling in, you can press *3 from your phone to raise your virtual hand, and we will send a request to unmute you. And those who have logged in, you will receive a prompt that says unmute me or stay muted. Obviously, want to press on the unmute me button, and then we will proceed. You also have another option if you aren't able to find the comment section in the Q&A. You can raise your virtual hand if you're logged in by opening the participants panel and hovering the cursor over your name, and a outline of a hand will appear and you can click on that to raise your hand. Thank you. I'll turn it back over to you, Chairperson O.
Thank you, Elizabeth. I'd like to take a roll call to establish a quorum. Members, as I call your name, please remember to open your line before speaking. Jig Patel? Jig is not here today. Indira Cameron Banks? Indira is not here today. Trevor Chandler?
Here.
Good morning, Trevor. Jesse Crowley?
Good morning, I'm here.
Hi, Jesse. And Jason Wise?
Morning, Sung.
Good morning, Jason. And I'm here. The quorum has been established. Members, we have a full agenda for our meeting today, including consideration of a number of legislative measures. I truly appreciate all of your time and commitment to the board and California consumers. I ask everyone participating today to be respectful of the work before the committee today. We encourage participation by members of the public throughout our meetings at appropriate times. We respectfully request that when comments are provided, they are done so in a professional manner consistent with how the committee conducts its business. Just also a warning that our meeting today may go very long. So to all the members, thank you and bear with us. I will now open the meeting for public comments for items not on the agenda. I would like to remind members of the public that you're not required to identify yourself, but may do so. I would also like to remind everyone that the committee cannot take action on these items except to decide whether to place an item for a future agenda. Members, following review of the public comments for this agenda item, I will ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Moderator, please open the line for public comment.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. If you're logged in and would like to participate, click the question mark inside of the square, typically located bottom right corner of your WebEx screen. In the text field that appears, type the word comment and make sure it goes to all panelists before you click the send button. For those calling in, you can press *3 from your phone to raise your virtual hand. Chairperson, no requests have been submitted. Would you like me to close the Q&A feature?
Yes, please. Thank you, Elizabeth. Members, with that, we're moving on to agenda item 3, approval of October 18th, 2022 committee meeting minutes. Included in the meeting materials is draft minutes from the committee's October 18th, 2022 meeting. As we begin, I will ask members if you have any questions or comments, and also if anyone would like to make a motion. I would like to also entertain a motion. I think Jesse,
I'll move
go ahead.
to approve the minutes.
Thank you. Just because you weren't there doesn't mean you can't motion or second. For Trevor and Jason, if you could help us.
Song, I'll second it.
Thank you, Jason. Jesse motions, Trevor second. And any other comments? Elizabeth?
Song, that was Jason.
Hi,
I
Jason.
seconded.
Oh, thank you.
Yeah.
All right. And we're ready for public comment, Elizabeth.
This is Elizabeth. The Q&A is open. Instructions on the screen. Again, click the question mark inside a square, type comment, send it to all panelists, or press *3 from your phone. Chairperson, I see no requests at this moment. Would you like me to close the Q&A feature?
Yes, please. Thank you. We're ready for a vote with a public comment. Jake is not here. Indira, not here. Trevor?
Yes.
Thank you, Jesse.
Yes.
Thank you, Jason.
Yes.
Thank you. And I vote yes, the motion passes. All right, moving on to agenda item 4, discussion and consideration of possible action on state protocol consistent with provisions of Business and Professions Code Section 4052.01 as amended in Senate Bill 1259, including proposed amendment to Title 16 California Code of Regulations, Section 1746.3. Members, as we discussed at our last meeting, the board previously considered and established a support position on Senate Bill 1259, which sought to amend Business and Professions Code Section 4052.01 to provide the authority for a pharmacist to furnish Federal Food and Drug Administration approved opioid antagonist in accordance with standardized procedures or protocols developed under specified conditions. The governor signed this measure, which became effective January 1st of 2023. As required in the statute, the board and the Medical Board of California must approve the regulation with consultation with the California Society of Addiction Medicine, the California Pharmacists Association, and other appropriate entities. The statute also specifies areas that must be included in the standardized procedures. The required protocol for pharmacists is included in California Code of Regulations, Section 1746.3, and establishes the requirements of the standardized procedures established for pharmacists to furnish naloxone hydrochloride pursuant to Section 4052.01. You may recall from our prior discussion that as products are approved by the FDA, it is appropriate to evaluate the board's current regulation to establish flexibility in the regulation for furnishing of additional opioid antagonists approved by the FDA. Since our last meeting, staff have performed a number of activities to develop language and secure feedback as required by the statute. I would like to thank Dr. Gasper sharing your knowledge and expertise in this area with staff to develop the proposed revisions we will be considering today. Members, Dr. Gasper is in attendance today and available to answer any questions. As required by the statute, following drafting of the proposed language, the draft was provided to the California Society of Addiction Medicine, who is offering one comment for consideration, which is moving a portion of the language to earlier in the section. No comments or concerns were identified by the Medical Board of California. I'm hopeful members had an opportunity to review the proposed language included in attachment 2. The meeting materials provide a summary of the changes being proposed. As required by the statute, this proposed change must be approved by the Medical Board as well. It is my understanding that assuming this committee recommends action and that recommendation is approved by the board during the February board meeting and will present before the medical board as part of its February 9th, 10th medical board meeting to request their consideration and approval. Having reviewed some background on the issue, process used to develop the proposal, and the process moving forward, I'd like to open up the discussion for members. I would appreciate your thoughts on the proposed language. I note that a possible motion is included in the meeting materials and displayed on the slide if you believe such action is appropriate. Members, any comments? Just a very, very complicated step just to allow our pharmacists to be able to provide naloxone in the state of California. So hopefully that this will be easier in the future, but Trevor?
Yes, I just want to say I think this is, like you said, it's better to get the details right and do it right the first time. So I appreciate all the work that went into this very nuanced discussion, something that's incredibly important during this opioid epidemic that we're facing, and making sure that everyone has the resources they need to fight it. So this is a particular passion of mine as someone who's in active recovery and on this board in that capacity as well, and just really appreciative of all the work that people are doing to really make sure that we're looking after those affected by the opioid crisis. And so I would like to make the motion on the screen to make the necessary changes.
Thank you, Trevor. Thank you for making the motion, and thank you for your comments. Jesse, your hand was raised. Just want to make
Yeah,
sure.
I'll second that. I just wanted to add that I think the language is great and removes barriers to getting access to naloxone and other opioid antagonists. So I second the motion.
Thank you. All right. With that, and before I go, any other comment? It's just, all right. So we're going to go for public comment. Elizabeth?
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. If you would like to participate, click the question mark inside of the square, type comment, and send it to all panelists, or raise your hand by pressing *3 if you're calling in. Have an individual identified as Keith Januszka. I apologize if I mispronounced your name. I will send a request to unmute your microphone in just a moment.
Sorry, Keith Yoshizuka.
Thank you. And I've just unmuted your microphone. I'm going to set the timer for 3 minutes, and please proceed.
Thank you very much, Keith Yoshizuka, California Society of Health System Pharmacists. I applaud this amendment to the regulation. It's been our position that such regulations and statutes should be promulgated for a drug class rather than an individual drug entity. So I think that moving in this direction will allow some flexibility and quite nimbleness as new drugs are approved as an opioid antagonist. Thank you.
Thank you.
Next individual identified as Stephen Gray. I'm going to send a request to unmute your microphone, Stephen. Request has been sent.
Can you hear me okay?
Yes, we can hear you. Thank you. Proceed.
Yeah, I would like to applaud the Board of Pharmacy making this change. It is very, very important. We are, as was stated, still in the middle of the opioid crisis. In fact, it's getting worse with all of the fentanyl, contaminated products and so forth on the market. So I encourage the passage of this motion. I would like to comment, however, that some of the board members may not realize that several companies have applied to the FDA to make naloxone products OTC. We expect that to happen. I think that there needs to be some discussion in the record of the minutes that how this protocol that you're adopting would apply, if it would apply, to pharmacists providing the products when the products become OTC. I doubt it, but it could be interpreted that that pharmacists are still restricted to going with this protocol, even if the FDA makes it OTC across the country. Thank you very much.
Thank you, Dr. Gray.
This is the moderator. No further requests have been submitted. Would you like me to close the Q&A feature?
Yes, please. Thank you. With a motion and public comment, we're going to go for a vote. And Jik is not here. Indira is not here. Trevor?
Yes.
Thank you. Jesse?
Yes.
Thank you, Jason.
Yes.
Thank you. And I vote yes, the motion passes. All right, moving on to the next agenda item. Agenda item 5, discussion and consideration of possible state protocol to facilitate pharmacist-provided medication-assisted treatment pursuant to Business and Professions Code Section 4052A14, including proposed addition of Title 16 California Code of Regulations, Section 1746.6. Members, as included in the meeting materials, Business and Professions Code Section 4052A14. Sorry for all the numbers. There's a lot of numbers today, a lot of sections. Provides authority for pharmacists to provide medication-assisted treatment pursuant to a state protocol. During our meeting today, we have the opportunity to consider proposed regulations establishing such a protocol. Do not intend to review all of the background information included in the meeting materials, but to help set the table, if you will, for this discussion, want to ensure we have a common understanding of MAT. MAT is used to treat substance use disorders as well as to sustain recovery and prevent overdose. Recently, and very excitingly, the federal law was changed to expand access to MAT, including removal of the X waiver, or some may know as data waiver or DATA waiver requirement. With this change in the federal law and the board's proposed regulation, I believe now pharmacists that choose to provide MAT will be well positioned to serve as an important access point for patients in need of MATs. Attachment 3 includes the proposed regulation language for our consideration today. You'll note from the meeting materials, experts in this field assist staff with the development of the draft proposal. As we begin our discussion on the proposed language, I would like to thank Dr. Gasper, Dr. Puzan Tian, forgive me if that's incorrect pronunciation, and Dr. Geyer for sharing their expertise with staff in the development of the proposed protocol. Members, I'd like to open us for a discussion on the proposed language included in attachment 3. As part of your comments and consideration, I note that the meeting materials and slide include possible motion language if you believe such action is appropriate. Dr. Gaspar is also available to answer any questions, and he is in attendance. Members, please go ahead and share your thoughts. Jesse, go ahead.
Thank you, President O. I think overall this is great. I do have a few questions that I think I need clarification on under, oh my gosh, which bullet is it? Oh, under B, it says that the pharmacist must ensure a confidential patient care area. I'm wondering what that means. Does that mean a private room? Does that mean that if it's off to the side and no one is around, that's acceptable? I think that clarification needs to be made. Also, a little clarification on what a physical assessment means and whether pharmacists are actually diagnosing substance use disorder if they're not being referred by a other provider. And also just kind of looking for comments and clarification on what it means to do so in collaboration with other healthcare providers. Does this mean referrals? I know there's part of the treatment plans that are required, but those are just some of the questions that I had about the current proposal.
Great question. Trevor, is it okay if we discuss Jesse's comments before I go to you? Okay.
Yes, absolutely.
I will say my response to the questions you have, Jesse, on the B, the patient confidential care area. That was just as this is a very sensitive discussion for patients to have. I would imagine that we would really want to ensure that this is not done in the hallways or just a random place sometimes that may not be appropriate. So we wanted to really provide that guardrails The other questions you have, it may be better that I have Anne and Dr. Gaspar respond, just because, sorry, Dr. Gaspar, I'm not trying to put you on the spot, but I know you worked with us on this proposal and you have extensive experience in this area of practice as well. So I will just defer these to Anne and you on that. So on the physical assessment, and also, I think, Jesse, you're asking about what does the referrals and all that means, right?
Yeah, and also the diagnosis, I guess, like whether pharmacists are actually diagnosing substance use disorder if patients are not being referred to them.
This is James Gasper. I will comment. On the assessment piece, I think it's important that we recognize that assessment's already built into the Pharmacy Practice Act for advanced practice pharmacists, and we can limit it to that definition. I think the difference between diagnosis and assessment is somewhat arbitrary, and we need to accept that at face value, a patient presenting with a history of substance use disorder and any signs or symptoms can be essentially assessed and diagnosed by a pharmacist. I think it's within our scope and it's appropriate.
Perfect, thank you. So I guess as a follow-up then, is this intended for advanced practice pharmacists or for all pharmacists, I guess?
This is open to all pharmacists. There isn't any restriction that, from my understanding in the statute, that would require it to be restricted to advanced practice pharmacists. I just use that as an example of how our scope has included assessment in other ways. It hasn't just been restricted to treatment decisions.
Thank you.
Does that answer your question, Jesse?
Yeah, I think it does. I would say, I think we need to maybe clarify confidential area to be a private area or a closed area. Just because I know there are pharmacies that maybe already perform certain services and don't actually have a private area. For example, like hormonal contraception and things like that. I know of pharmacies where they're not being done in a private area, and I would want to ensure that we actually have that listed in the statute. I think that was the biggest concern I had, but I think everything else makes sense. Thank you.
Thank you. Trevor?
Yes, thank you so much. Very excited by this. One question I had, I love the advances that are being made in MAT as part of, I firmly believe in all the above strategy when it comes to recovery and addiction. And I think this is a really exciting method. I wanted to just get clarification about how it goes about, because this says under the initial A pharmacist may initiate, modify, administer, or discontinue. So with MAT, can it be initiated by any practitioner, whether it's a psychological practitioner? And how does MAT get initiated? How does the process start? I'm assuming it doesn't have to start with a pharmacist, but this rule will allow a pharmacist to initiate it. Could you just educate us on kind of how an MAT would come about, and if it's not initiated by a pharmacist, how a pharmacist would get plugged into a process that's already begun?
Thank you, Trevor. Great comment, and I'm gonna again punt this to Dr. Gasper because he actually works in this space, and I think also he might be entering into uncharted territory himself as well because of the new changes in the federal law with the X waiver removal. So if you could just comment on that as well, that would be really great, Dr. Gasper.
Absolutely. I'll give a little history on this. Up until the change in federal statute, the only drug that pharmacists haven't been allowed to prescribe under a collaborative practice agreement has been buprenorphine for opioid use disorder. We've had authority to prescribe buprenorphine for pain, for all high-potency opioids, every other controlled substance under the sun, except for this one drug, which is something that I think fits squarely within our wheelhouse in terms of treatment and patient contact. So if this is a huge change in the statute, adding that to our authority is going to be very useful. This regulation takes it one step further in California and requires, actually removes the requirement for a collaborative practice agreement or a relationship directly with the provider that gives us this authority. So this is the ultimate and low barrier access to treatment. Somebody presents to a pharmacy and very quickly we can make the assessment that somebody is in need of treatment. It's not just OUD, but also alcohol use disorder and any other substance use disorder for that fact. We can very quickly make an assessment about the appropriateness for treatment, which often needs to be done on the spot. And the collaboration from that point forward is up to the pharmacist's discretion to bring in other healthcare providers, make additional assessments, connect them with psychotherapy. Those things are all downstream, and that's the way that substance use disorder treatment really should happen. A lot of the decisions need to be made quickly to save people's lives. The further assessment and additional treatment requirements can be brought in over time. We don't want to put that burden on people up front, and this removes it, and it puts pharmacists in a great place to do it.
Mm-hmm. Thank you, Dr. Gasper. Thank you for your work on this. Thank you to the team, to the staff that worked to put this together. I think taking this initial action to start this rulemaking and further refine and get it right, as per what Jesse was talking about, I think this is a really important first step. Like I said, as someone who's in recovery and has my own path that didn't go through MAT, I'm a firm believer in an all the above approach because no one path works for everyone. And especially given that pharmacists are on the front lines of the addiction crisis and seeing people up close and personal and be able to take that action immediately. I think this is a really important first step in us, or additional step, not a first step, because Lord knows we've done a lot and we have a lot more to do. So thank you all for that. And with that, I make the motion on the screen.
Thank you, Trevor. I have Jason hand raised. Jason?
Yeah, thank you, Sung. In speaking to Jesse's concerns on privacy, I want to know, maybe Anne, you have the answer. When we make these rules and regulations in law, are there similar circumstances where we mandate that privacy must be maintained, and how does that perform in the real world?
Great question, Jason. Anne?
I don't know that I have a great answer, although, sorry, you have a great question. I don't know that I have a great answer. I would say that, in general, pharmacies have a lot of patient-sensitive information. They're required to provide a lot of patient counseling and those kinds of things with HIPAA. I would say that we do receive a number of complaints from consumers who feel that their health information was shared in a fashion that they believe is inconsistent with the law. We conduct investigations, and I would say we substantiate violations in that area. What Jesse, I believe, was suggesting was potentially, instead of saying a confidential patient care area, to a private. So I believe that one word, I think, if I'm understanding Jesse's recommendation correctly, might be, a change. I don't know if a closed office is necessary. Dr. Gaspar may be able to talk about how it's currently being done, if there are such provisions. But I think in general, Jason, yes, we do receive complaints about this in general, and we do at times substantiate those violations.
Oh, okay, thank you. I certainly don't want to inhibit the public's use of MAT. So if there is a way to thread this needle, I'm certainly open to that. Thank you.
Thank you, Jason. Jesse?
Thank you. And you're correct. I think a private patient area for me makes more sense and kind of covers our bases. And the last comment I have is just a concern of this being launched in chain retail pharmacies and not having that time, that really dedicated time to actually come up and develop a thorough treatment plan and have that private area. But overall, I fully support this. Some background myself too. I have a brother-in-law who actually died of an overdose from mixing buprenorphine and alcohol. And so I'd like to believe that had a pharmacist done a thorough consultation, that could have been prevented. And I realize that pharmacists are some of the most important people who can help provide those consultation points for patients. So I also fully support this bill.
Thank you, Jesse. We have a motion on the table. Anyone want to second the motion? I'm not trying to pressure anyone. Eileen, go ahead.
Hi, I just had a question because I think Member Chandler moved for the motion, but he wasn't considering possibly Member Crowley's comment to make the change to subsection B to private.
Sure. But we don't have a second, so I just want to make sure, do you want to get that change, Jesse, for you to second? I'm not trying to pressure anyone to second.
Dr. O, I'm fine with my motion dying without a second.
Oh, no, I don't want it to die. I think we
can go back to it. We can have it not be second and then a new motion with the second.
Good. Okay, we'll change it. Do you want to change it?
Trevor, would you like to amend your motion to move the language, to move as presented on the slide with one change to the language changing from confidential patient care area to private patient care area in B?
Correct. I would like to amend my original motion from confidential care area to private care area.
Sounds great. Thank you.
I'll second that. So
thank you, Jesse. Thank you. All right. Any other comment before I open up for public comment? Okay, we're going to go for public comment, Elizabeth.
This is the moderator. The Q&A is open. The instructions are on the screen for your reference. If you would like to participate, click the question mark inside of the square, typically lower right corner of your WebEx screen, and type the word comment in the text field that appears, and make sure to send that to all panelists before clicking the send button. If you are calling in, you can press *3 from your phone to raise your virtual hand. I am setting up my timer, and I do have individual identified as Stephen Gray. Stephen, I'm going to send a request to unmute your microphone in just a moment. Request has been sent. Just click the unmute me from your end.
Thank you very much. I really do support this. However, I think that changing the word from confidential to private is a mistake. It implies that it has to be private in the sense that, completely enclosed or substantially enclosed. And where confidential just means that the pharmacist has to be sure that it's reasonably confidential regardless of the physical setting. Changing it to private could eliminate many pharmacy situations where this could no longer be done. Having said that, it's important for everybody in the committee to realize that in many situations, this won't be done in a pharmacy at all. We have a lot of pharmacists who are working in medical offices, clinics, and other environments where they do have a private area. They probably have one of the exam rooms, just like you would see in a normal physician experience. So I would recommend that you withdraw the motion and keep it at confidential. We have a lot of information and history as to what confidential means. Confidential has special meaning, special for pharmacy under federal HIPAA rules, and does not, and the HIPAA rules do not require the same type of private setting that is required for a physician examination and other situations. There are special rules that apply at the HIPAA privacy under the Office of Civil Rights that allow pharmacies to be a little more open and trust the pharmacist to know when it has to be confidential and the amount of privacy that's needed. So I support the idea, but I don't think that the word should be changed to private for those reasons. I would hate to see a lot of pharmacists can't do this because someone has said that private means more than what they have available traditionally. We deal with a lot of prescriptions for erectile dysfunction and STDs and everything in pharmacies today without having a private setting, a separate enclosed areas. Although some pharmacies do have that, it's quite varied, as was reported throughout the state. Thank you very much.
Thank you for the comment, Dr. Gray.
Next individual identified as Keith Yoshizuka. I'm going to send a request to unmute your microphone. Request has been sent.
Thank you very much. Keith Yoshizuka, California Society of Health System Pharmacists. This is really exciting. We've been waiting for this for quite a while for the X waiver to be removed. I wanted to make sure, and I think the language in the proposed regulation is broad enough so that it's not interpreted that this is the only route. There are other institutions that may be developing collaborative practice agreements for pharmacists to furnish MAT. And I want to make sure that this regulation doesn't preclude use of those individually developed collaborative practice agreements, through your large organizations such as Kaiser Permanente, Sharp Healthcare, and maybe Sutter Health. So thank you very much.
Thank you, Dr. Yoshizuka.
We have an individual call-in user 4. I'm going to send a request to unmute your microphone. You are unmuted.
Hi, good morning. This is Jantine Yesterday. I'm a pharmacist in the community setting in Southern California. As much as I want to see something like this available, I either don't understand or I feel like I have some concerns regarding the distinction in private versus confidential. I don't feel like we should make any changes to what's already available or what's already in place in the pharmacy. We have requirements to have a confidential area for consultations, vaccinations, and I would hate to see that changed. My concern with this is, while it's wonderful to be able to offer these consultations to patients who need them, and it's important that we do so, I think there's, at the community setting, not always the discretion of the pharmacist and corporate pressures to offer certain services. And if they're not set up with a physical place to do so, that we would require the same for prescription consultation, immunization, or an extended consultation, it does raise some concern for me.
Thank you for the comment.
This is the moderator. No further requests have been submitted. Would you like me to close the Q&A feature?
Yes, please. Thank you, Elizabeth. When I first thought about this proposal, I didn't think that we would be having to discuss private versus confidential, but of course, we always have things. That's why we saw a lot of great love of collaboration. With all these comments, I see Jason's hand is raised. But before I go, I don't know, Eileen, did you want to say anything about this legality of this? Or I'm not trying to put you on the spot, but.
I'm sorry, President. Oh, this is Eileen Smiley. I don't know what you mean by the legality of what.
The privacy versus confidential. Private versus confidential.
I think that's just a matter of what the board's viewpoint is about what they want to do. I mean, you have federal HIPAA rules that govern in the privacy area, but you also have an explicit constitutional right to privacy under California's constitution as well. So I think this is really a question for the board. If they believe that making it private is better versus confidential and leaving any breaches of confidentiality to the investigation process, then you can keep it as confidential. I think it's really a determination by the board. There is no legal prohibition for requiring a private area versus a confidential area.
Okay. Jason, your hand was raised.
Yes, thank you, Sung. I think that, my primary intention here is to make sure that we provide MAT to as many people as possible. I know that sometimes our pharmacists fail on the confidentiality front, but that is just human nature. And so I think I would like to go forward with the motion as originally written. That would be my preference. but obviously I cannot make such a motion just yet.
All right. Okay. Trevor, are you standing by your motion?
Well, a question of, so this is a process question. So this is the initiation of the rulemaking process, correct? So what we pass now, we can, if we are to initiate the rulemaking process, we can make note of this important discussion that needs to happen as part of the rulemaking. So my question to the chair is, if we pass the motion as is, or I will yield to Jessie as to what her thoughts are on the on her preference versus privacy over confidential. But as a general process question, what we pass here isn't the be all end all to this conversation, correct? It's something that
Trevor, absolutely not. This is just the one of the regulatory process, the joy.
I think this is an incredibly important conversation. I'm really appreciative of the concerns brought up. And as this is step one, I think the fact that we are having it is important. So I am at this point in the process agnostic as to whether we amend the motion to private versus confidential, as long as we know that this is a very important aspect that we need to address in the next couple of steps, one way or another.
Thank you. Yeah, I mean, we haven't, if not, submitted initial rulemaking as far as I know. And please correct me. So this is gonna have to be happening to go that far. And just that alone will take quite a bit of time. And I'm sure staff can develop some language in that package to add something about, this discussion. So I am supportive of that as well. Go ahead, Anne.
Yeah, should it be helpful? You can, one of the things that you can do is also flag this as a policy question for the full board, right? Because you're offering a recommendation to the full board. And so as part of the meeting materials to the full board, you can offer the motion, but then say the committee would also like the full board specific input on specifically the question of using the term confidential versus private.
And just for the process-wise, the steps that would be needed is that if we do pass this motion, it would have to go to the full board in a couple weeks. And then if that passes, then Anne and the staff would develop rulemaking package. Then once that goes through, we'll have 45-day comment period and all the steps that will have a lot of opportunity for public to voice their concerns as well. So I wish regulation was this simple. Just we vote and then it happens, but obviously it's not. So, all right, with that, are we good with the votes? Okay, I'll take that as a yes. We'll vote. Jig is not here. Indira is not here. Trevor?
Yes.
Thank you, Jessie.
Yes.
Thank you, Jason.
Yes.
Thank you, and I vote yes. The motion passes. Thank you, Dr. Gasper, for attending today and assisting staff in developing these regulations. We truly appreciate the support you have extended us, not only for the meeting today, but in the past and throughout. Really appreciate it. So agenda item 6 is the discussion and consideration of pharmacists provided HIV pre-exposure and post-exposure prophylaxis, including presentations. Just before I go on, I'm gonna make sure I take a quick 5-minute break so that Dr. Maria Lopez and Dr. Hopkins, everything is working. And so you all are ready to go. So we'll take a quick 5-minute break. We'll come back at 9:50.
I'm here, sorry.
Thank you, Jessie and Jason.
Here.
Thank you, Jason. And I'm here. So much easier when it's just 4 of us instead of 13 in about a couple weeks. All right, so members, as detailed in the meeting materials, there are a number of ways in which a pharmacy can engage with a patient to provide HIV PrEP and PEP, including through traditional dispensing functions, through collaborative practice agreements, and through provisions established in Senate Bill 159. As you may recall, during the October board meeting, we received a presentation on research underway on pharmacist-furnished HIV prevention. The result of the research is not yet available. However, when it is, the board will receive a presentation on the outcome. Today, we will receive presentations on pharmacist-driven models currently used to expand access to HIV PrEP and PEP. I would like to invite Dr. Lopez, President and Residency Program Director with the Mission Wellness Pharmacy. Dr. Lopez, the floor is yours. I believe you're going first, right? Okay.
Sure. Good morning. Thank you for having me here to speak. It's an honor. I just want to start with a disclaimer that any comments that I provide today or recommendations during this presentation are not the opinions nor recommendations on behalf of Get SF-CIBA nor the American Pharmacists Association, where I have been doing consulting work. Next slide, please. The Get SF-CIBA is housed within the San Francisco Department of Public Health and is part of the National CIBA Provider Network. CIBA stands for Capacity Building Assistance, provides technical assistance in non-clinical HIV testing and prevention for HIV-negative persons. CIBA is funded by the Centers for Disease Control and Prevention, and as a result does not provide official policy recommendations. Next slide. These are the topics I will be discussing. Next slide, please. So I'm going to start by putting up these two studies that I think are really important for background in pharmacy HIV testing and PrEP services. The first one is the Virginia Department of Public Health in collaboration with the Centers for Disease Control and Prevention, which was funded by the Centers for Disease Control and Prevention, conducted a study with 32 pharmacies, chain pharmacies, Walgreens pharmacies in the state of Virginia in areas of high need. The pharmacists performed approximately 3,600 tests, so demonstrating high numbers of tests by pharmacists in a community pharmacy setting. As I mentioned, it was in high need. Over almost half of patients had never been tested, and that's really remarkable data because it shows that pharmacies are able to access people who need testing. We know that if people are not tested for HIV, then they're not aware of their status and they can't take measures to help prevent spread of infection, meaning to get into treatment. The thing I wanted to point out also about this is that for the positives, the positive patients were connected in the pharmacy over the phone with a counselor who connected them into care and helped guide them for their next steps with their positive rapid test. The next study below is the Kelly Ross Pharmacy in Seattle, Washington, and they implemented a collaborative practice agreement with a private physician. Now, Washington State passed a very landmark legislation in 2015 that went into effect January 1 of 2016. So this pharmacy was able to benefit from the landmark financial legislation that mandated payment for all providers for clinical services in the state of Washington. That said, they were able to midpoint presented at a conference that 23% of their patients had a primary care provider. So that meant that 77% did not have access to a primary care provider. And that's really important and very, was really seminal for pharmacy-based PrEP that they were able to reach patients that do not have access to a provider. They also showed very high rates of adherence and retention. I don't have that on this slide, but retention was loss to follow-up was 25%, which means a retention of 75%. That's much higher than we see in the real world in non-pharmacy settings. So in medical settings, we see retention at 50% or below. So again, demonstrating that decreasing barriers for patients to access PrEP by going to one location, having their labs done, and seeing the pharmacist. Here in the pharmacy was demonstrated to have increased retention and adherence. There are other studies outside of pharmacy where low barrier PrEP is also offered. And for this reason, the CDC and many partners in the HIV community are very interested and excited about pharmacy-based PrEP. Next slide. This is just a map of all of the pharmacy PrEP and PEP specific bills that have been passed in the country since 2019. California was the first state to pass a PrEP and PEP bill. There are a few states that are not listed here. There's other states that have not passed specific legislation around PrEP and PEP, but have expanded scope so that pharmacists are able in those states to initiate PrEP and PEP. As you can see, Washington State is not one of those states. Next slide. Just breaking down the states that have passed specific PrEP and PEP legislation, I broke them by states with restricted quantities. California is in that bucket. As I mentioned, it was one of the first in the country, or it was the first, I should say. For unrestricted quantities, we have 5 states that have passed legislation that allow pharmacists to provide ongoing PrEP and PEP. And the other thing that I just highlighted here was reimbursement. In the unrestricted quantities bucket, we have 4 states that have mandated reimbursement at 100%. Some of them are still working out the laboratory payment, but 2 of them, Colorado and Nevada, do mandate laboratory reimbursement. Next slide, please. The CDC designates 57 priority jurisdictions as of high need, meaning that there is very high HIV incidence in these jurisdictions. And these are 57 jurisdictions across the United States. California has 8 of those jurisdictions, as you can see here, and San Francisco County is one of the 57 priority jurisdictions. California also, the CDC tracks annual infections, and 2019 is the latest data that is most reliable. CDC's 2020 data is not as reliable. They saw a marked decrease in the number of new infections, and we believe that is not a real number and due actually to lack of access to care in medical care and lack of access to testing in 2020 due to the COVID-19 pandemic. So there were approximately 36,000 new infections in 2019 across the United States, and almost 4,400 were in California, so a little bit less than 10%. Next slide, please. This is a slide with data from the CDC. The data is from 2018 and 2019. The CDC has priority communities. These are communities with high impact. So HIV affects these communities the most. And PWID, P is persons who inject drugs. They account for approximately 10% of annual infections. By gender, the CDC defines gender by sex at birth, listed on the birth certificate. And when they break up by gender, persons assigned male at birth comprise 81% of new infections on an annual basis. So they are most affected. Male sex at birth are most affected by HIV, and women account for 19%, which is approximately 7,000 based on the latest data. Again, among men, defined by the CDC, gay, bisexual, and other men who have sex with men account for 70% of annual infections, latest data. So really disproportionately affects this population of men defined by the CDC. The CDC does know that trans individuals are highly impacted by HIV, and historically the CDC and public health departments have not had a mechanism in place to track consistently trans individuals. That is changing somewhat. This is just data from a survey that the CDC conducted over several large cities in 2019 and 2020 among trans persons who identified as trans women. And we can see among trans individuals that Black and Hispanic are highly impacted among trans women. By race, when we look at all genders, HIV disproportionately affects Blacks, African Americans, and Hispanics and Latinos, who comprise together approximately 3/4 of all new infections in the US. The CDC also recognizes and knows that based on the data that the communities that are most at need, and I'm in this case talking about by race, and actually all of the communities, but they have done a lot of data looking closely at race, and we see that persons who need PrEP the most are not accessing it. I don't have that information, that slide up here, but among Blacks and Latinos and African Americans and Hispanics, it is there is a huge disparity between the need and accessing PrEP. So the CDC is very supportive and interested in low barrier PrEP mechanisms so that patients can access PrEP. Next slide, please. In 2018, Mission Wellness and the San Francisco Department of Public Health initiated a pharmacist-run PrEP collaborative practice agreement. The program is overseen by the physician of record at the San Francisco Department of Public Health, and the San Francisco Department of Public Health provides support and supervision. Under our collaborative practice, the phlebotomist or a nurse can draw blood, pharmacist sees patient, the nurse can do some of the clinical activities as well, and a pharmacy technician or peer counselor assist with benefits navigation. The program has received limited grant funding through the CDC and the City and County of San Francisco. We did publish findings from the first year of our program. 51 patients were initiated on PrEP and 6 patients received PAP. We saw that 60% utilized navigation assistance, which for our definition was that they were enrolled in a manufacturer assistance program, meaning that they did not have insurance. So they were not insured, which we also believe that most of them were not engaged in care. Our program was really supported and funded because San Francisco, like many areas of the United States, does see inequities in Hispanic, Latinos, and Blacks and African Americans. And so the purpose of the program was to increase uptake in these populations. And in our program, we reported that 47% of patients identified as Hispanic, Latino, and 10% as Black, African American, demonstrating that we were reaching these populations. In San Francisco County, these two populations make up 15.7% and 5.7% of the county demographics, respectively. Next slide. This is just an overview of our workflow. We see patients. The initial visit does take longer. It's almost about an hour approximately, and then follow-ups. I probably didn't mention, but we see patients for ongoing PrEP care. Those visits are 30 minutes. The way that it works is a patient comes in, completes an intake questionnaire. Our staff completes insurance benefit navigation. The pharmacist then reviews the assessment, sees the patient, orders labs. PrEP is given only after a rapid negative HIV test, and then we see patients for ongoing care. Next slide. Some of the barriers and facilitators of our program I've listed here. The implementation was a huge list for us. We did undergo construction at our site. We only had one private room for confidential conversations, and we added 3 additional rooms. We also took it from start to finish, from when the county gave us the go-ahead and we started working on the program. It took 20 months, and that was just all of the documents that had to be reviewed and signed by the county health department as they were overseeing and supporting our program. So that was a huge lift and took a lot of time. The ongoing barrier that we continue to see is that the funding is very limited, and we're unable to bill for pharmacist-initiated services. The DHCS, Medi-Cal, and ADAP have rolled out some reimbursement at this time. We don't really have very many Medi-Cal patients, and in fact, I don't think we have any currently that are in our program seeing PrEP. They just rolled that out a year ago. And then the ADAP program, Office of AIDS, ADAP, has rolled out a program, but it doesn't provide coverage for tests, and neither does the Medi-Cal program cover the cost of the test, nor the ADAP program does not cover the visit. The Medi-Cal program does. Given that it doesn't cover the ADAP program, which is most of our patients would probably benefit from, doesn't provide ongoing reimbursement, we have not enrolled in that program. And it's a little bit complicated because we do have some funding from CDC So we have to, at this time, we're not billing, and it really, in my opinion, would not be worth it for us today to do that, given that there's not reimbursement for the actual visit. Facilitators for our program, I believe that having the collaborative practice agreement and really is a facilitator for us in allowing us to do ongoing prep. I just cannot see how we would do this if it were just giving prep one time to a patient and then sending them off for all the work that's done for the patient. I don't believe that that would be feasible for us, no financially nor for the time. So having a collaborative practice agreement for ongoing prep in this situation is important at this time. We have referrals in place both with the public health department and community partners in the area. And so having that infrastructure in place that we've been working in the community for 18 years in HIV at this location. The pharmacy is from in the Mission, which I should say is a historically Latino neighborhood of the city, and has been in the Mission since 1978. But we've been providing care for HIV patients for 18 years. So we have referrals and collaboration working in the community with our medical partners. Our laboratory tests are supplied by the public health department. All of our samples that are collected on site are sent to the public health lab. And so we have a lot of support for the laboratory tests. And so that has been a great facilitator for us. Next slide. This is, I put a slide that summarizes some of the barriers in my experience. I do want to mention, I'm not talking about it just for the interest of time, but there is a small survey that was conducted at the University of California, San Francisco, and they surveyed they surveyed over 1,000 pharmacies, but then they excluded a lot of pharmacies. Chain pharmacies were excluded, for example, and they came up with 9 independent pharmacies with less than 4 locations was their definition. And 7 of them were providing PrEP and PEP in the San Francisco Bay Area. 2 were in the process of providing PrEP. So they surveyed those 9, and I've combined some of their responses, and I'll talk a little bit about it as I go over this slide. The pharmacist in that study did bring up the 60-day limitation, which I do believe is a barrier for SB 159. I've already talked about the financial. In my opinion, it is very necessary to support testing, staffing, and education. And in that small survey, they brought up financial as well. The pharmacists were interviewed, so they mentioned what their barriers were. Education, we know from that survey, we saw some points that were brought up. The pharmacists were not aware there was a need in their area when they were surveying them, and we just that is just wrong. It's we do know there is need. And so there is a lack of education for pharmacists. And that's been really demonstrated in a number of studies that have been done in other states, larger studies looking at education. We know these drugs were approved, the first drug for PrEP was approved in 2012. And so there's a lot of pharmacists that were never trained that are practicing today and were never trained on these medications in pharmacy school. And HIV training is limited. And that's why SB 159 required the training requirement. They also saw awareness of patients was low, or they said that, and we know that too from the literature in PrEP, and that's one of the big reasons why PrEP is not accessed, because the communities that need it the most are not aware to get HIV, how to protect themselves for HIV testing, or that these medications are available and how to access these medications. The last point I want to talk about is that I was involved in SB 159 in the process, and from the beginning, my understanding with the legislative officers was that the intent was for pharmacists to follow the best practice guidelines and guidance, which is from the CDC, and that's what we do with other disease states. We always follow best practice guidelines. I do think that there are some issues with the language today that could be more flexible, and as a result of how the language is structured, it is somewhat of a barrier. Obviously, the 60-day limit is the legislative language today defines the guidelines as the 2017 guidelines, and it says or updated, which is fine to say that, but it limits it to the guidelines. And the CDC, for context, publishes the guidelines every 5 to 6 years. However, CDC is continually updating recommendations and issuing updated guidance that are not part of the official, quote unquote guidelines. And so I think that the language needs to be more flexible and permit other CDC guidance documents, or even to just say in accordance with CDC guidance rather than guidelines. There are some parts of the legislative language that I've looked over, and just in my experience, the medications, for example, are specifically listed. I haven't seen that with other pharmacist scope of practice laws in California, and that was sort of a new thing. It is a barrier because medications get approved and recommended, whether they're FDA approved or not FDA approved, they will get recommended by the CDC, and then that means that the legislative language has to be amended. And I think that the more prescriptive that we put into the legislative, it makes a barrier for pharmacists to practice, and is not what is in intent. And I believe that's the end of my slides, but can I see the next slide, please? Oh, I just put up this slide. The reason why I wanted to share this is that San Francisco County CBA has created a PrEP basics document. We use it for all of our county. The medical clinics use it as well. It's a one-page English on one side and Spanish on the other. And when naloxone, I was involved a little bit in teaching pharmacists about naloxone use. And the Board of Pharmacy put up a similar document that the SFDPH had created. And I think that this document for sharing for pharmacists would help pharmacists, one, to educate them about the medications, but also so that they could use it. The intent really is to use it with patients to educate them about how to take their medicine and how PrEP works. The other, I have one more slide in addition to this one. And we have two documents. I've only put up one. These were created by CBA to help support pharmacists. For SB 159, this one is a 2-page specific document with main points. And then we have a larger 8-page document that talks about really the CDC guidelines and how it summarizes them for pharmacists. And that's the end of my presentation.
Thank you, Dr. Lopez. We really appreciate you coming on here. I'm sure our members probably have some questions for you, so I'll open up for members. Trevor, go ahead.
Dr. Lopez, thank you so much for this, especially being a resident of San Francisco and the Mission. The fact that we have your leadership, not only in the city, but the state and the country on this, I think it just makes me very proud to be a Mission resident and a San Francisco resident. So thank you for that. And especially with your CBA documentation, I'd like to ask the staff if we could get the CBA resources added to the board's website as an additional resource for pharmacists, given that we have obviously an education gap in how pharmacists are able to engage on PEP and PrEP. Because especially coming from the LGBTQ community here in the city, it's only right that San Francisco is a leader given our very direct history on this. So with one of the things I've noticed as I have been diving into this issue, it seems like the reimbursement for tests, especially just at a broader level, seems to be one of the biggest hurdles facing getting this SB 159 actually getting the PEP and PrEP in the hands of pharmacists. It seems that from how I followed the bill being going through the process last time, test reimbursement was originally in SB 159, but had to be taken out for legislative reasons to get it across the board. Dr. Lopez, do you think do you think that getting full test reimbursement in addition to expanding beyond the 60 days, do you think that'll be key to making sure that all pharmacies across the state are able to like feel empowered to actually prescribe PEP and PrEP?
Yeah, it's more than just though the laboratory test. The time for the patient visit has to be reimbursed as well. And I think that Washington State has really set the gold standard, and we see other states starting to follow to mandate payment for all of the PrEP services, including lab.
Got it. Yeah, it seems to me like SB 159 was a good step, first episode, groundbreaking first step. But I know in California, we tend to set the bar and then others try to come for us and take the bar from us. And I'm very proud because of the work of folks like you, we set that bar that others are now getting past us. And now it's time for us to set the bar again. And so I really look forward to figuring out ways that we can work together, both at the board level and beyond, to really fix what needs to be fixed so we can get PEP and PrEP across the state. When I see those numbers of 2019, the 4,000 people who have gotten HIV AIDS, I mean, part of me is very grateful for the fact that we have such incredible treatment that HIV AIDS is no longer a death sentence. But at the same time, I feel every person that could have been prevented either through PrEP or PEP. And I see those thousands of Californians across the country, and I see that California cities are at the top of the CDC's list. It seems like an incredibly preventable tragedy that we at the board and then obviously at the legislature and following your leadership at the community level can bring that number down to zero. So thank you for your work. Thank you for bringing this to our attention, and thank you for the work that you're doing and will do on this topic. And please let us know how we can help endorse in any way.
Thank you.
Thank you, Trevor. Any other member comments before I open up for public comment? Jason, go ahead.
I just wanted to thank you, Dr. Lopez, for your presentation. I found it very thorough. If you could you please remind me what adherence rates were and how did those compare for people in your program as opposed to like the general public, if you have that data?
That's a good question. We haven't broken down our adherence rates. Our program, as I mentioned, has had limited funding, and to be honest, we have struggled, particularly with the pandemic. And the city, there was some money that came through for ending the HIV epidemic through San Francisco, but with the COVID pandemic, that money was not rolled out in time. We just found out that we're going to be getting additional funding. We had intended to complete, and we did put through IRB at UCSF to publish the results of the findings. So I don't have those numbers in front of me. And I can't comment on our site specifically, but we do track patients. We have seen numbers go down during COVID, and they are starting to come back up. Did you want me to remind you of the adherence rates that we saw at the Kelly Ross Pharmacy? Was that the one you wanted to see?
In general, but yeah, at the Kelly Ross also specific, please.
Yeah. So what I can say is that Kelly Ross reported a proportion of days covered of 90% of patients had a proportion of days covered greater than 80. And that a PDC of greater than 80 proportion of days covered is a good measurement of adherence. So they showed very high adherence. And that adherence rates in some PrEP studies, they vary, but they are lower. So the pharmacy-based program did show very high adherence.
Okay, thank you. And thank you for your presentation.
You're welcome.
Thank you. All right, Dr. Lopez. As a public agency, we provide an opportunity for public comment. Public comment is not intended to be a question and answer session. However, you are more than welcome to respond to questions if you are comfortable to do so. Comments or questions are raised during public comment and members are interested in your thoughts. We also may ask for your response following comments. So let's open up our public comment. Elizabeth.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. Those who are logged in and would like to participate, click the question mark inside of the square, typically located bottom right corner of your WebEx screen. And once the text box appears, enter comment or type in comment and make sure it goes to all panelists before clicking the send button. For those who are calling in, you can press *3 to raise your virtual hand. So I'm going to set my timer here, and I have first individual, Keith. Let me find your name to unmute your microphone. Give me just a moment. And Keith Yoshisuka, I've unmuted your microphone.
Very good. Thank you. Keith Yoshisuka, California Staff Health System Pharmacist. I appreciate the presentation, and I'm glad that Dr. Lopez pointed out one of the limitations, particularly the 60-day limitation on PrEP, but there is none on post-exposure PEP. And when the bill passed, while we all applauded it, we were a bit taken aback because we were limited to only a certain number of days supply or period for pre-exposure. And basically, it occurred to me that, maybe as promoting preferable for post-exposure treatment. So if there's a way so that we can modify the statute to, as she said, the recommendations as opposed to guidelines, that would be much appreciated. Thank you.
Thank you, Dr. Yoshisuka.
This is the moderator. No further requests have been submitted. Would you like me to close the Q&A feature?
Yes, please. Thank you. Jesse, your hand is raised. Go ahead, Jesse.
Yeah, I'm just wondering, maybe this is more a question for Anne, but at a future meeting, if we can take a look at some of the language in other states, particularly Washington, to see what sort of changes maybe in the future that we could potentially make to ours to make it make there be less barriers to getting HIV PrEP medications.
Anne, did you want to respond? I'm unfortunately we require legislative changes, and Dr. Lopez's hand is raised. Go ahead, Dr. Lopez.
Yeah, I would just say that the biggest facilitator in Washington State is the financial, and that's SB 5557. That is different from how pharmacists in Washington State practice. It's their scope of practice is a CDTM that is reviewed by the Board of Pharmacy for each pharmacist and approved at the Board of Pharmacy level. I don't believe that that's something that the California board could do based on my experience in contacting the board. I know there's limited staff. And I think that looking at, really what Colorado, Nevada, and some of the states that have had unlimited practice or that are adding protocols. There are states that have adding protocols. Idaho just added one that, I don't want to mix this up, but there are states that are adding protocols. For example, in the Dakotas, pharmacists have been able to, for many years now, at least 10 years, conduct a CLIA wave test and give a patient, for example, a CLIA wave test for flu and give them the medication if they were positive for flu or positive for strep. And that is something that would be very helpful in California with the COVID-19 pandemic. We are limited. We just recently were allowed to conduct any CLIA wave test, but we cannot provide therapy. And I believe that Idaho is a state also that recently just passed a legislation like that.
Thank you so much for all that information. Yeah, I think it would be very helpful to kind of have a separate agenda item in the future to kind of evaluate how other states are operating with this.
Sounds good.
Yeah,
Trevor?
Jesse?
Oh, go ahead, Anne. Sorry. Go ahead, Anne.
Jesse, I would say that there's probably some touch points also with standard of care and the work that that committee is doing. And I'm hearing that some of this is, some of the barriers may be more in the reimbursement world. So from the staff perspective, happy to look and see how some of the other jurisdictions are approaching reimbursement specifically to see for future agenda items.
Perfect. Thank you, Anne.
Thank you, Anne. Trevor?
Yeah, just one more thing that I meant to touch on that I was impacted with in your presentation, Dr. Lopez, the 10% of these HIV/AIDS infections coming from drug users, intravenous drug users. And I just want to make sure that we're connecting this to also the previous topic we had as we're moving forward, new rulemaking on how we can best treat addiction. If we're going to fully treat the opioid crisis that we're dealing with in our communities, we have to be holistic about it. And the fact that there may be a barrier at our pharmacies who are now creating medically assisted treatment plans and all of these amazing things that we were moving forward earlier in this. If we're not fully incorporating this HIV prevention work, and if pharmacists at the same time are not able to be reimbursed for the HIV prevention work that they're doing while at the same time potentially treating addiction, I think that it's just a failure of our system. And so that was another key takeaway that I had from your presentation of looking at this from a very holistic approach of everything we're doing that pharmacists are on the front lines on, and we need to remove as many barriers as possible to make sure that we're doing that. So just again, thank you for bringing that to our attention, and especially as we had just talked about the naloxone expansion definition and the MAT. I think everything we're dealing with today ties together. So thank you.
Thank you for bringing that up. It was something I did listen and just want to call out that harm reduction for persons who inject drugs is part of PrEP care and in the language and part of the training. So it is important to tie those together because pharmacists should be doing both in addition to oral contraceptives and other harm reduction techniques for injection drug use.
Thank you. Thank you, everyone, for your comments. Now, Dr. Lopez, please stay around if you could. Hopefully, we might have more conversation after Dr. Hopkins' presentation. So we're ready to move on to the next presentation. Thank you so much again for coming. Dr. Hopkins, CEO of Pucci's Pharmacy, and Pucci's, that's such a cool name, Pucci's Long-Term Care Pharmacy. Thank you for coming and speaking to us and giving us presentation. Floor is yours.
Good morning, President O and board members. Thank you so much for having me today. My conversation today is going to tie on to a lot of the things that Dr. Lopez presented, discussing implementing SB 159 in my pharmacy. Next slide, please. So Pucci's Pharmacy, the background on Pucci's, we did open in 1930. The Pucci brothers founded it back then and sold it to Tom Nelson in the 70s. And then Tom ran it for another 30 years before he sold it to us. Tom, the previous owner, Dr. Nelson, was one of the first pharmacists to service patients living with HIV in the 1980s. Back in the day when other pharmacies would run them out with a broom because they were afraid that they were going to get HIV from them. Tom welcomed them with open arms. That was a very important selling point for me purchasing this pharmacy and taking over this business because as an LGBTQ pharmacist, I wanted to provide care to a community that I connected with that had been underserved traditionally. So as you can see from our numbers here, we did treat 200 for HIV, PrEP, and PEP in 2020, 282 in 2021, and 303 in 2022. So it is growing. And while we do see the number of PrEP prescriptions going up, unfortunately, we also see the number of new diagnoses going up as well. Patients served for RX, as you can see, over the pandemic, we've grown quite significantly, our delivery services, and our reach has helped us to grow quite significantly. In 2019, we obtained our CLIA waiver. We were well ahead of COVID on that, and we were doing that so that we could do flu and strep testing. I am an advanced practice pharmacist, as we discussed, and I have a collaborative practice agreement with a physician to oversee our services here. We wanted to get into HIV and hepatitis C testing from then. That was the purpose of obtaining the CLIA waiver. So of course, when COVID rolled around and surprised us all in late 2019, we were ready to start doing COVID testing as soon as we were able to get our hands on those tests. Next slide, please. In January 2021, we were one of the first non-chain pharmacy sites in California to vaccinate against COVID in collaboration with the Sacramento County Department of Public Health to provide mobile vaccinations. We went around to assisted living facilities, skilled nursing facilities, residential care for elderly facilities all over the county of Sacramento to provide vaccines to those who were at greatest risk. To date, we've administered more than 27,000 COVID vaccines in Sacramento County. In July 2022, we were contacted by the Sacramento County Public Health to assist with the Mpox or monkeypox vaccines. The county recognized that we had a connection to the community that was most affected, the LGBTQ community, and also that we had done great work with COVID vaccinations. So they knew we knew how to roll out vaccinations, and that's why they reached out to us. We have to date given 6,268 Mpox vaccines through this pharmacy. Most of them here in the pharmacy, but we've also done quite a few pop-up events around the county at places where people are found, mingling, different events, bars, clubs, sex clubs, wherever we can go to meet those patients and get the vaccines in their arms. In 2022, this past year, we did start providing Apretude, which is HIV PrEP, and Cabenuva, which is HIV treatment injectables in the pharmacy. So the physician sends an order to us, indicates on the order that they want the pharmacist to administer, and then under the collaborative practice agreement with the physician that I have here, Dr. Randy Martin, we do administer those in a private room. I have 2 clinic rooms that we built out here in the pharmacy, and we have been administering those to patients with great success here at the pharmacy. Next slide, please. So SB 159, as Dr. Lopez mentioned, she and I both were advocates for this bill and were testifiers to get it passed. It does authorize pharmacists to initiate and furnish HIV PrEP and PEP. It expands the Medi-Cal schedule of benefits to include HIV PrEP and PEP as pharmacist services. It prohibits plans and insurers from requiring step therapy or prior authorization to antiretroviral drugs. And it prohibits plans and insurers from prohibiting or allowing a pharmacy benefit manager to prohibit a pharmacy provider from providing HIV PrEP and PEP. I wish that I could tell the board that plans were just doing this on their own because it's in the law, but unfortunately they are not. I just most recently, as of last week, I can tell you on January 12th, I had a rejection for a patient for getting PrEP, and they said they needed to get it from a mail order pharmacy in order to get PrEP. And I had one great big battle with that insurance plan, and I won't say their name on this call. I'm sure someone from that agency is on this call, but I told them I expect to hear back from them to let me know that this is not going to continue to occur in this state, not just for patients at my pharmacy, but for patients at any pharmacy. And I am sad to report that I have not heard back from anyone, but I will probably be reaching out to the Department of Managed Healthcare to let them know that this plan is in violation of SB 159 already. Next slide, please. So SB 159, pharmacist requirements. Pharmacists must complete training for competency. They must be able to perform HIV testing or have access to HIV testing for those patients to receive the medications, provide HIV counseling, prescribing, dispensing. There's PrEP and PEP counseling, and then we need to notify the PCP. So as you can see, there are a lot of steps. It's more than just handing out pills. Next slide, please. SB 159 for PrEP, specifically in 4052.02E1, it states that the pharmacist must ensure that the patient is HIV negative. So this burden falls on the patient to prove that they are HIV negative as documented by a negative HIV test result obtained within the previous 7 days from an HIV antigen antibody test or antibody-only test from a rapid point-of-care fingerstick blood test approved by the FDA. If the patient does not provide evidence of an HIV negative test, the pharmacist shall order an HIV test. So SB 159 has given us the authority to provide this test, to order it, to send them to the lab, or to do it here in the pharmacy. But nowhere in SB 159 does it mandate that that service will be covered. Next slide, please. SB 159 for PEP, or post-exposure prophylaxis, also indicates in 4053.03E2 that we shall ensure the patient is HIV negative. And in this case, it doesn't really specify that the burden is on the patient here, but it's still a burden on the pharmacist to provide HIV testing that is classified as waived under CLIA, or determines the patient is willing to undergo HIV testing consistent with CDC guidelines. If the patient refuses to undergo HIV testing but is otherwise eligible for post-exposure prophylaxis under this section, the pharmacist could provide or could furnish post-exposure prophylaxis. Next slide, please. So we look at this from a perspective of coverage, and Dr. Lopez has kind of already touched on this. We have our Medicaid patients, they're covered by Medi-Cal, and that's about 25% of the population of California. Then we have those uninsured patients, which are covered by the PrEP app program. The pharmacy must contract separately with CDPH to bill the PrEP app program. I have been in the process of doing that. Unfortunately, there are some discrepancies there between the amount that CDPH is willing to pay for the services that are provided and the amount that labs such as Quest and LabCorp are going to charge us. So again, we're stuck between a rock and a hard place. If I want to provide these services, I'm going to be paying more for the labs than the PrEP app program is going to reimburse. So it would be a financial loss for the pharmacy, which unfortunately makes this unattainable for the pharmacy and for the patients that we need to service the most. So these would be the uninsured patients that would be covered by this program. By far and away, the largest percentage of Californians are covered by commercial plans. And in SB 159, there is no requirement for these plans to cover pharmacist-provided HIV testing or to recognize the pharmacist as a provider for non-dispensing related services. Because there's no requirement, they're not just going to say, oh, we want to do this because it's the right thing to do. We have to require them to do it. Sacramento County Department of Public Health has offered to share their HIV tests with us. And while we greatly appreciate this offer and we would love to do it, we would still lack funding for the pharmacist's time spent providing the test, for counseling and all the other steps. As you saw, it's more than just testing and providing pills. There's a lot of counseling and a lot of discussion that needs to go on around HIV, the risk levels, the continued prevention, how patients are exposed to HIV, and then, of course, the medications. There's lots of paperwork with the Sacramento County Department of Public Health that needs to be completed. It's several pages, and it would need to be sent back to them every day. And this might work for me, right? I have a really strong relationship with my Department of Public Health here in Sacramento County, but it doesn't work in every county. It doesn't work for every Californian, so it's not viable for most pharmacies. Next slide, please. So our current state here at Pucci's Pharmacy, we are referring patients to willing providers. I have a network of providers across the county that I have cell phones for probably half the doctors in the county. And I will text them and say, hey, Trevor's come in today and he's indicated he would like to get on PrEP, and I would like to get him on PrEP right away. And so I will do a warm referral and hand them off to a provider, and hopefully we get them a prescription for PrEP that day or the next day. And that's working really well, but some patients see that, and I'm kind of skipping around here a little bit, but some patients see that as us pushing them off and not wanting to deal with them. And I don't like that patient perception that we don't want to help them, because we want to help them. We do have the LGBT Center, who is just up the street from us here. They do test and they refer to a telehealth provider. So those patients get their prescriptions. Typically, those prescriptions are sent to another pharmacy. They don't always send them to me. And those patients have reported, sometimes they come back and let me know that another pharmacy didn't want to fill their prescription, said they couldn't get it in stock, delays resulting in potential, continued exposure. Also, some patients, they don't want to go to the LGBT Center or an HIV/AIDS center because there's a stigma around that. They may not identify with that community, and they may not identify, they don't want to be seen at an HIV/AIDS center. I've had patients tell me that. And so it creates a barrier to ask them to go there if they don't want to be in that space. So Pucci's dispenses HIV PrEP, PEP, and treatment every day. And referring out, like I said, it often causes a delay in start. Patient may get infected during this window. We have seen that happen where patients seroconverted got infected during the window where they were waiting to get started on PrEP. The patient perspective, or perception overall is negative of the healthcare system, which we don't like. And while this does work greatly, like I said, in Sacramento County, I've got a great network of willing providers. That's Sacramento County. You get outside of Sacramento County, and this is not viable for pharmacies who don't have a willing referral destination. Next slide, please. So what we'd like to see is we'd like to see removing the barriers to care. We'd like to see pharmacists to be able to provide testing upon request. Patient walks in, I want to get an HIV test. Great, let's go in the other room. I'd like to give you one, and we'd like to talk with you about PrEP and PEP today and get you started right away. We'd like to be able to do that immediately. We'd like to see a mandate that pharmacies are able to be reimbursed by all health plans for HIV testing and all related professional services. We'd like to see a removal of the 60-day limitation of initiating and providing PrEP once in a 2-year time frame. And I think, as discussed by Dr. Lopez and others on the call, and I can't point it out enough, that we have this extra level that LGBTQ plus patients are subject to, whereas we have services like naloxone and services like oral contraception that women and folks who would be using those services are not subject to, and it's not fair, and it needs to be addressed. And that is all. Ready for questions.
Thank you, Dr. Hopkins. Really appreciate it. Trevor, go ahead.
Thank you so much, Dr. Hopkins, for your advocacy. And there was a very interesting piece that I wasn't aware of that I was hoping you could elucidate a little bit more on, which is about the PEP. I didn't realize with PEP that you did not need a test as long as you fit all the other aspects. So, I mean, there are some pharmacies who will say, we're not going to provide PEP because of the test funding mandate, but is this to say, like, if someone were to come into a chain pharmacy or any pharmacy and say, like, I would like PEP, would the pharmacy still be able to prescribe that and get fully reimbursed for PEP?
It is written in SB 159 that way, that a patient could refuse HIV testing and obtain it. It is my opinion, I would just sit down and discuss with that patient that it is not in their best interest to do that, because we would want to know on the front end, before we start you on PEP, are you already HIV positive? Because if you are, giving you 30 days worth of PEP and then having you discontinue that therapy thinking that you are now, out of that window, but you were originally positive from the onset, it's medically irresponsible, and I wouldn't want to do that. So I would greatly discourage any patient who asked me to give them PEP without an HIV test from doing that. But it is, as I understand SB 159, written in the law that way.
Thank you. That's very clarifying for me, because I'm just trying to, my main goal is to get, just like you and Dr. Lopez, is to get PEP and PrEP as accessible as possible. And so learning these distinctions for me is very helpful. So thank you for that. And thank you for touching on the fact that there still remains a stigma throughout the state, especially in certain segments of the industry as it relates to the LGBTQ community. I know in California, we've made, comparatively to a lot of other states, a lot of advancements in acceptance of the community, but the fact remains throughout the state, including in places like here in San Francisco or LA, or places we think would be, or in Sacramento, places we would assume there would be a greater acceptance and less of a stigma. Even in these places where the community is perceived as being much more accepted, there's still a stigma there. And part of the reason we have these bills is and we have these rules is specifically to make sure that even the bad apples or the folks that may need a little pushing to get to where we need them to be, so we make sure the community is protected, is there. And so thank you for your advocacy on SB 159 as we hopefully try to fix those pockets to make sure that we're protecting everyone in the entire state. I think the point you made and that Dr. Lopez made, and I'll amplify it again, is especially with people that are talking about over-the-counter contraception, all these OTC things that people are able to get immediately. There's no reason that the LGBTQ community should be discriminated against in getting immediate treatment for something that overwhelmingly impacts them directly in their community. I think that's something that needs to be highlighted as we work to figure out what the best way to do this is. So thank you very much for all of your advocacy and your work and for everything you and everyone in your pharmacy does, because I know you as a leader are doing this. Dr. Lopez as a leader is doing this. So I know you have an incredible team working with you to make all of these things happen and to increase this access. So thank you to all of you.
Thank you, Trevor.
Thank you. Thank you. Jesse?
Hi, Dr. Hopkins. Thank you so much for the presentation. I do have a few questions for you, mostly surrounding, I guess, the day-to-day processes. So some of my questions are kind of how long does it take for someone who's first time coming into your pharmacy if they want to get tested for HIV? How long does that process take? And then I'm kind of want to figure out how many tests you do per day and then what your staffing is like so that you can actually provide these thorough services.
Sure. So I would say the turnaround time is 24 to 48 hours for most patients. We're able to find them a provider that can get them in either the same day or by the next day for testing. The number of tests that we have done for HIV in this pharmacy is 0. And the reason for that is because of the reimbursement issue. I can't have Jessica come into my pharmacy and tell me I was assaulted and I need to get tested for HIV and I need to get a prescription for PEP. And then I turn around and assault Jessica again and say, that's going to be $100 for your HIV test. That's not right. I can't do that. So we're not testing here. We're referring those patients out so that they can get tested somewhere where it will be covered or it will be funded by a grant or somewhere that they won't have to pay out of pocket for their HIV test. And I'm sorry, you had some other questions about staffing. So I do have 3 other full-time pharmacists here at Pucci's in addition to myself. Like I said, I do have 2 private clinic rooms where we can see patients and have those private conversations with them about HIV and their risk and PrEP and PEP. And we give vaccinations and do COVID tests, flu tests, strep tests in those rooms as well. And then I think that answers everything.
Yeah, I think you answered those questions. An interesting point that you brought up, which I am looking for more information on, is just I wasn't aware of the prohibitions on insurance from restricting these medications. So I'm wondering, in your opinion, how we can educate pharmacists about this part of the Senate bill and what pharmacists can do to navigate these situations when they do occur.
Yeah, I think it definitely is worthwhile for us to put together an education piece to send out to pharmacists, and maybe the board would like to send an email out to everyone to let them know that if they get these rejections from insurance, how to handle that and how to escalate it to first, of course, try to resolve it with the plan. And if you're unable to resolve it with the plan, then the Department of Managed Healthcare oversees the plans and to report it to them.
Perfect. Thank you so much for all your work. Yeah, I mean, you're helping your community so much, and it's really nice to see that happening. Thank you.
Thank you, Dr. Hopkins. Thank you, Jesse. Jason, I'll go to you, and then I'll go to you, Dr. Lopez, after. Thank you.
Sung, if you don't mind, I'd like to hear from Dr. Lopez first. She may cover what I'm asking.
Go ahead. Absolutely. Dr. Lopez?
Sure. So I just wanted to cover a few points that I've written some notes here. First, on the PEP, I know it was discussed about the test. I just want to point out that the CDC guidance allows for PEP to be initiated without an HIV test. The recommendation is, of course, that an HIV test be conducted prior to starting PEP, but PEP does have the 72-hour limit, and it's very important because as time passes, the efficacy of PEP decreases based on the data. So we want patients to start as soon as possible and definitely within the 72 hours. And because of that, the CDC guidance does permit initiating PEP prior to the HIV test. There was some discussion about insurance plans, and I wanted to bring that up as well, that it's my understanding that in California, when we were going through the legislation, and this is something that we probably should confirm, that employer-based plans are allowed to require mail order, and that has been a barrier at numerous times where we have HIV positive patients who lose their HIV positive medicines, and the insurance plan will not allow the local pharmacy to dispense the medication. And I think that requirement exclusion for employer-based plans is where we see the negative, or not the negative, but the denial at the point of sale, because that's in my experience where I've seen it with employer-based plans. And then I wanted to say that in my experience, we also did a lot of COVID testing and vaccines since the pandemic. We've done over 100,000 procedures, and we are still to this day, and COVID is really a good example, because we were able and data is showing what the impact pharmacist was across the country on the COVID pandemic. We were able to provide those services, Dr. Hopkins and I and many other pharmacists, to any patient, because we knew that it was mandated by the federal government to provide COVID testing and vaccines. And both of us went off-site to numerous sites where we provided COVID vaccines, for example, to patients that had many insurances. And so today, for example, Kaiser still has to pay for a COVID vaccine. But during the winter, when I was at schools and there were teachers that had Kaiser insurance and needed a flu vaccine, Kaiser will not pay for a flu vaccine because it's not required. And only because of the COVID mandate can we provide the COVID vaccine. So I think that's a really good example to show here. Regarding insurance plans, I and Dr. Hopkins, I believe in our conversations that we've had with them denying even our COVID test, even though there is a mandate, they're not paying for them. And that really is a discriminatory process by action by the insurance plans, that they are not recognizing that we should be reimbursed as pharmacist providers. And I just wanted to bring that up as a discriminatory action by the insurance plans.
Thank you, Dr. Lopez. And Jason, go ahead.
Thank you, Sung. Dr. Hopkins, I really want to thank you for your presentation, and thank you to you and Dr. Lopez for all of your COVID outreach and vaccinations. Really came through in a clinch when we needed you. If the moderator could go back a few slides to where I really appreciate how concise your recommendations are. So I don't know if I heard you right. Is Medi-Cal right now, we are okay? Medi-Cal's paying or reimbursing for these issues, and reimbursement issues are only with the uninsured and people with individual work-based health care. Is that right? Or health insurance?
Well, I can't exactly tell you that we're 100% okay with Medi-Cal. I can tell you that it is included in the language that Medi-Cal is supposed to cover it. Dr. Lopez might be able to speak more to that. The reason I can't tell you is because we haven't done it. I don't want to have testing over here that's only for a certain group of people, and then other people come in and I say, sorry, I can't provide it to you because you're insured, or I can't provide it to you because you're, I don't want to have to tell some people I can do it and others I can't. I don't want to be in that situation. So we just aren't providing it to anyone. We're referring everyone out.
Okay. And has the needle moved at all with the insurance plans? Are they authorizing or reimbursing anything more so than they did at the beginning of implementation of 159?
As far as from a perspective, the only thing they pay for is prescriptions for medications at the pharmacy. And, year over year, we see those reimbursements go down every year, and it's not getting better. So,
okay.
Dr. Lopez.
Thank you.
Jason, I just wanted to answer that question. So private insurance plans, as Dr. Hopkins pointed out, none of them are paying for any of the services for PrEP and PAP. For the pharmacist services nor the laboratory. Medi-Cal has a system in place to pay for the pharmacist visit, but We have been told that they do not have a payment process in place to pay for any pharmacist-based laboratory test. And so testing is not covered by Medi-Cal. And we have not billed for the services to date. It does take quite a bit of work to do the paper billing, and we have probably, I don't know, we might have one patient in our PrEP program on Medi-Cal right now, so we haven't tried to do that one. And then ADAP, AIDS Drug Assistance Program for uninsured patients, will only pay the one-time initiation for the, they're actually paying a incentive fee to enroll them in the ADAP program. And they're not paying for the visit nor for the laboratory test. Is that correct? Correct me if I'm wrong, Dr. Hopkins.
I have another call with them later this week. Actually, it's either tomorrow or Thursday to continue going over the application. But as I mentioned earlier, the thing that's going to hold us up with that program is that Quest, LabCorp, they have a rate, let's say it's $500 that they're going to charge the pharmacy to send a patient over for an HIV confirmation test, and the program is going to pay $35. So I don't know, does anybody own a pharmacy that can lose $465 every time they see a patient? I don't have that kind of extra money laying around. So we're trying to figure out how CDPH can contract directly with Quest and LabCorp to have this is the rate we're going to pay you, and don't make me the middleman or the middle person here. Just go directly to them and pay them directly and negotiate these rates with them. So I hopefully will know more about that soon. But also, as I mentioned, that program is only going to cover about 10% of Californians, and the lion's share of Californians are covered by private plans and by Medicare. And so that's where we really need to address this, is with the commercial plans.
Understood. Thank you both.
Thank you, Jason. Dr. Lopez, did you want to say something?
Oh, I just wanted to answer those questions.
Okay, great. All right. Thank you. Thank you both. I really appreciate it. Dr. Hopkins, as a public agency, we provide an opportunity for public comment. Public comment is not intended to be a question and answer session. However, you are more than welcome to respond to questions if you are comfortable doing so. If comments or questions are raised during public comment and members are interested in your thoughts, we may ask for your input response following public comment. Elizabeth, if you could please open the line for public comment. And Dr. Lopez, since you're here, would also welcome you to provide any thoughts if you are agreeable. Thank you.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. If you're logged in and would like to participate, click the question mark inside of the square, typically lower right corner of your WebEx screen, and type the word comment in the text field that appears. Make sure that it sends to all panelists before clicking the send button. If you are calling in and would like to participate, press *3 from your phone to raise your virtual hand. Chairperson, at this time, no request for public comment. Would you like me to close the Q&A feature?
Yes, please. Thank you both very much for presenting today and sharing your expertise. Members, I would also like to share a few thoughts before we move on. The last 3 agenda items have all highlighted the unique access points pharmacists provide to expanded care for patients and the legislature's recognition of pharmacists as appropriate healthcare providers to engage in such expanded patient care activities. I believe this theme has also been identified through the Standard of Care Ad Hoc Committee. I believe there are actions we can take to remove barriers to care, but I believe actions must also be taken by others, including payers, to fully recognize and actualize this expanded access to care. I would also like to work with the Office of AIDS to expand education on funding sources available for pharmacists, if any. I believe it is appropriate to also convene a dedicated meeting to discuss the challenges experienced with reimbursement for pharmacist services, and would suggest that such meeting be convened after the results of the research is available, which I believe will be coming in the months. Members, any comments before we proceed to the next agenda item?
Chair, could we take a 5-minute break?
Yes, yes, thank you, Trevor. All right, thank you, Dr. Lopez and Dr. Hopkins. Really appreciate it. And if your schedules permit, we would appreciate your continued participation. It is 11, so we'll come back at 11:10. 11:10, everyone. See you in a 10-minute. Oops, sorry, I was muted. It's 11:10. We're gonna get started again. I see Trevor back, and Jesse, are you back?
I'm back, yes.
Sorry, Jesse. And Jason?
Here.
Thank you, Jason. All right, moving to the next agenda item, and I'm here. Agenda item 7, discussion and consideration of possible action on discontinuance of business by a pharmacy and potential changes to Title 16 California Code of Regulations, Section 1708.2. As you may recall, during our October meeting, the committee initiated review of the board's requirements for discontinuance of business. I draw your attention to the relevant provisions of pharmacy law noted in the meeting materials. The board's current discontinuance of business, I'll call it DOB, process requires notification to the board. As highlighted in the meeting materials, the current provisions in the law do not establish conditions for continuity of patient care, which I believe is very problematic and appears contrary to the board's mandate. During our last discussion, we discussed general areas of complaints received related to this issue, including scenarios where a pharmacy has closed and a patient cannot receive a refill because they're unable to contact the pharmacy to request a prescription transfer, or where a pharmacy has closed and transfer patient prescription refills to another pharmacy, not of the patient's choosing. We also considered a number of policy questions which are also detailed in the meeting materials. After consideration of the issue and policy questions, as a committee, we determined changes to current regulation requirements was appropriate. We requested that staff develop proposed language for our consideration. Today, we have the opportunity to review the language prepared by staff. Members, I note that the meeting materials summarize the proposed changes and that attachment 4 includes the proposed language. I am hopeful you had an opportunity to review the language. You will note the meeting includes some policy questions that are necessary today to discuss to further refine the language. First question is the time frame within which the notice must be provided to impacted patients. So I will start. Anyone who wants to share any thoughts on this, go ahead, raise hand. Jesse?
Thank you, Sung. I know we kind of discussed at the last meeting, and initially I proposed like 30 days was a little more reasonable. Having just gone through an acquisition myself at my store where a pharmacy nearby had closed, even at the pharmacy level, we were given less than a week notice before the acquisition actually occurred. And I was getting complaints from patients months later. Now that we're about 3 months out, there are very few patients left from that pharmacy who are, who aren't aware of the acquisition. But I will say there were still a significant amount of patients who weren't aware of the acquisition after 30 days. And one of the biggest barriers, I think, comes with patients who may have controlled substances, where federally we're only allowed to transfer them one time. So if the patient was unaware of the closure, they end up getting their prescriptions stuck at that pharmacy, which was, unfortunately, I commiserate with them a little bit because I'm like, yeah, I'm sorry, there's nothing that I can do. You have to get your doctor to send a brand new prescription over. But all of that is to say that I think 30 days for me personally would be the bare minimum, but I think something closer to 60 days would be more reasonable to give patients enough time to run out of whatever medications they have and actually be aware of any closures and make the necessary changes if they need to.
Sounds good, Jesse. I know from the last meeting, I think there was some discussion from the stakeholders of the challenges of it being too long. So I will try to be mindful and say, I think that 30 days is where I would support as well. But understanding that there's a lot of business decisions, but again, that we have to be mindful of the patient care. So that's where I will say. And any other member comments in agreement or disagreement or indifference? All right, so we'll leave at that. Next question, the parameters defining the patients that must receive the notice. In other words, patients that received a prescription filled within the last 365 days. Just to note that our disciplinary language actually is 60 days, I believe, or 30 days it may be. I have to double check that. But just considering that, I know that what we require may be even more tougher than the disciplinary guidelines, but I think it should be at least at a minimum 90 days, in my humble opinion, just because a lot of patients receive 90-day prescriptions or 100-day prescriptions nowadays. So I think I would say minimum 90 days is how I feel, but I'm open for considerations.
I would say that it should be longer. I have some patients who actually live half the time in another place. And so, I mean, I think it's reasonable. Prescriptions that non-controls anyway are good for generally best practice for a year. I would say anyone within a year, that if they still have active prescriptions and they're valid, I would imagine that they should be notified if they've picked up within a year.
I think within a year is reasonable as well. Any strong disagreement to that? Other members? No? Okay. All right. So that, moving on to the next question, the committee wish to specify the type of written notice via email, written correspondence is acceptable, or does the committee believe any form of written communication is sufficient? In this area, I personally would not want to make it too complicated, as it is already very difficult. But, you know, as I think pharmacists are required to have patient's address on record, most pharmacies, I will tell you, would not have patient's email, and there's not even a way to communicate. It is actually very, very rare that I know a lot of pharmacies keeping emails of patients' email addresses. So that may be very challenging. So with that, members, any thoughts?
I would just say keep it. My methodology is always to keep it as simple as possible, and so I agree with you. If mailing address on file, which everyone should have, I assume, that seems like the most logical thing to me. So.
Sounds good. Any other comments? All right. Anyone want to make a motion?
This is Jessie. I'll make the motion, Sung.
Thank you, Jessie. And seconds?
I'll second.
Thank you, Trevor.
President O, I just wanted to check because we have 30 days in the proposed language. Does the motion mean for to provide the written notice at least 30 days in advance? I'm just not sure.
Oh, thank you, Eileen. For me, the motion would be for 30 days in advance.
Trevor, are you agreeable? Sounds good. Thank you. Thank you for, Trevor is shaking hand, yes, head. So I just want to make sure that that's reflected. All right, with a motion and second, before I go to public comment, I'm sure we'll have public comment on this. I'm gonna sure there's no other member comments. All right, moderator, please open the line for public comment.
This is the moderator. The Q&A is now open. Instructions are on the screen for your reference. If you're logged in and would like to participate, click the question mark inside of the square and type comment in the text field that appears and send to all panelists. If you are calling in, you can press *3 to raise your virtual hand. So I'm now going to look through the Q&A, and I do have I will go first with the individual who raised their hand, Maria Lopez from, going to send or actually you can unmute yourself. I will set the timer for 3 minutes. and then we'll go with individual in the Q&A feature.
Yeah, I just wanted to make a comment about this, that with technology, pharmacies are allowed to have now access to text messaging and email, and I know that was mentioned. And I just wonder if there's a way to put, if that needs to be, if it's necessary to put that as an option, because I do think that having the multiple ways to communicate with patients, and we do use text messaging just to remind them about their refills, and so that could be a way to also notify them about this, the change in the closure. That was my only comment.
Thank you, Dr. Lopez.
Next, individual identified as Stephen Gray. Stephen, I'm going to send a request to unmute your microphone in just a moment. Request has been sent, and I'm going to set the timer for 3 minutes.
Thank you very much for the opportunity to comment. I believe that the questions that were posed are connected to part of the proposed language, which is that the pharmacy that is going to go out of business is going to send a copy of the notice to the Board of Pharmacy. I think that there should be some discussion about what the Board of Pharmacy is going to do with that notice, or what it does with the notices they get now. So for an example, if you set the limit at 30 days in advance, but the patient didn't get it in time, and there's no way to contact, or they don't know who to contact, is the Board of Pharmacy going to provide the service, since they have the information of where the prescriptions were sent, the identity of the pharmacy from which they may be able to get future refills, et cetera? Is that part of why the Board of Pharmacy is going to get the notice? If that's not what the board anticipates, then I think the longer period should provide. For an example, most Medi-Cal patients are entitled on chronic care medications, at least a 60-day supply, and they're not even going to be looking around to get the next refill for probably well after the 30 days. And then they're going to go in and find the pharmacy is closed. And we all know that many Medi-Cal patients have problems with transportation and other services, and may not be able to even get mail in some cases. So I think that should be considered as to what the Board of Pharmacy is going to do. Are they going to post this information? Are they going to require the closing pharmacy to actually post on a website if they have this information, so that when people go in to order on their website, that they know that the pharmacy is going to close or has closed, and where they can get the future information? I think those are very important things to consider. Thank you very much.
Thank you, Dr. Gray.
This is the moderator. No further requests for public comment. Would you like me to close the Q&A feature?
Please, thank you so much. All right, with that, motion and second and public comment, members, are we ready for vote? Okay, Trevor, how do you vote?
Yes.
Thank you, Jesse.
Yes.
Thank you, Jason.
Yes.
Thank you, and I vote yes, the motion passes. We'll be discussing this further at the full board meeting. Agenda item 8, discussion and consideration of legal requirements for non-resident pharmacies, including possible statutory change to require licensure by the pharmacist in charge. Members, today we will resume our policy discussions on potential changes to licensure requirements for the pharmacist in charge working in a non-resident pharmacy. The meeting materials include the definition of a pharmacist in charge as a pharmacist proposed by a pharmacy and approved by the board as a supervisor or manager responsible for ensuring the pharmacy's compliance with all state and federal laws and regulations pertaining to the practice of pharmacy. As required by law, every pharmacy must designate a PIC, pharmacist in charge, who is responsible for the pharmacist's compliance with state and federal laws. California law requires that any pharmacy located outside a state that provides services into California shall be considered a non-resident pharmacy. Further, this section requires licensure as a non-resident pharmacy. There are no current requirements for pharmacists working in these pharmacies to be licensed in California, even when providing care to California patients. Further, there is no requirement for the PIC of the non-resident pharmacy to be licensed in California. Rather, California law currently just enables a prohibition for pharmacists providing services to California patients if the pharmacist license was revoked in California. During our prior meeting, we reviewed the model rules provided by the National Association of Boards of Pharmacy, provided for boards to consider as part of its regulation of the practice of pharmacy. Regarding the regulation of non-resident pharmacies, the model rules include a requirement for a pharmacist to be licensed in the state in which it is providing services to patients. Members also review the range of requirements other states require for licensure of staff working out of state but providing care to their residents. The materials also provide a few examples of actions taken against non-resident pharmacies. During our prior meeting, members spoke in support, in general, of establishing a requirement for California licensed pharmacists to be the PIC of a non-resident pharmacy, while also identifying some potential challenges. Since our last meeting, staff have developed post-statutory language for our consideration, which is included in attachment 5. Members, I had the opportunity to work with staff in the development of this language. I believe it strikes a balance and will move the board towards a model regulation, such entities that improves patient care in California. I welcome your comments on the proposed language, and I note that the meeting materials offer a possible motion, which is also displayed on the meeting slide. And I would also entertain a motion if you believe such action is appropriate. Members? Jesse, go ahead.
Hey, Sung. I did have one note, I think. Let me see where it is. Under section D, where it says a prerequisite to registering with the board, the non-resident pharmacy shall identify a California licensed pharmacist employed and working at the non-resident pharmacy to be proposed to serve as the pharmacist in charge. I just want to make sure that my understanding of that is correct, that they need to physically be working inside the non-resident pharmacy and not just like a virtual person working within the company who's designated as that PIC. Am I understanding that correctly?
That I'm going to refer that to Eileen because I would think so, but I think that's going to be up to our counsel to confirm.
President, hi, I am just looking at that, and that could be subject to interpretation. It's also something the board could decide to further clarify with regs as well. But the way I would read it, it's employed and working at the non-resident pharmacy. You know, if they had corporate headquarters there, I think technically a California licensed pharmacist working in headquarters could technically qualify under that section. So I think we would have to look at precisely what the board wants to do. And I think we have different avenues with that, like with respect to wholesalers and some other things. We have other people who are designated for a non-resident to be California licensed or designated. But the way I read this, employed and working at the non-resident pharmacy doesn't necessarily mean that they're working as the pharmacist. They're actually processing. They could be in management is the way I read this section.
Thank you, Eileen.
I will say that that's a little bit concerning to me. I think like the intention of designating a PIC, at least from my perspective, was that there would be actually someone physically there to supervise and to ensure that everything was being followed. I think it touches upon another issue that we had kind of brought up, which is that in California, we don't have a minimum number of hours that a pharmacist in charge needs to be in a pharmacy. So I do have some concerns about that. I don't really know how to change it, but I'm curious to see what everyone else thinks in terms of that language.
I personally would be supportive of amending it to leaving. I don't I think that it's more of, for me, I am just hoping to start one layer at a time. So I would support leaving it as it is. Because I don't want to create too much disruptions. I also just want to make sure that there is a strong pharmacist in charge, legal authority, and their responsibility in doing it. And it's not always physical location. I think it could be just broader and them just having more autonomy and power to do and make changes. So I'm open to any amendments, but I think that this is a good first step.
Hi, this is Eileen, President O. I just wanted to also check on D. The way I read this is it's saying as a prereq to registering with the board, they have to identify a California licensed pharmacist. Do we have someplace in here I was trying to go through that says to maintain the registration, they also have to maintain? Because technically the way that's written is they designate it upon the registration and then they could drop it, or are there maintenance requirements beyond the initial filing of the registration with the board?
I think that might be contained in section C above.
Thank you, Anne.
Okay, thank you. I'm glad we clarified that. All right. Anyone want to make a motion?
I move the motion on screen.
Thank you, Trevor. I know, Jason, you're going to have to stay quiet on this, so I understand.
I'll second it, Sung.
Thank you. Thank you, Jesse. All right, with the motion and second, I would imagine we'll have some public comment on this as well. So we'll open it for public comment.
This is the moderator. The Q&A is now open. The instructions are on the screen for your reference. If you're logged in and would like to participate, click the question mark inside of the square, type comment, and make sure it goes to all panelists before clicking the send button. For those who are calling in, you can press *3 to raise your virtual hand. And at this time, let me set up my timer. I do have Lindsay Gullahorn who would like to make a comment, and I'm going to send a request to unmute your microphone in just a moment. Request has been sent.
Thank you. Good morning. This is Lindsay Gullahorn of the California Retailers Association, National Association of Chain Drugstores. I'll keep my comments brief. I know I've stated them when this was discussed before. I just want to note that as we previously commented, we do have concerns with requiring non-resident PICs to obtain licensure in California and think it will have a negative impact on access to pharmacy services here, given the burden it will place on those non-resident PICs. We feel that there are other options to ensure non-resident PICs have a sufficient understanding of California law, like registration, which has been done in Iowa, and given the additional steps, costs, and requirements that go into licensure and maintaining a separate California license. So again, just would recommend the committee not pursue a licensure requirement. Regardless, do look forward to engaging in the legislative process on this. Thank you.
Lindsay?
Next individual identified as Mark Johnson. Mark, I'm going to send a request to mute your microphone.
Thank you, Board. This is Mark Johnston with CVS Health. Recognizing the cost to both consumers and licensees of overly burdensome multi-state licensing requirements, the FTC published a policy perspective in 2018 addressing occupational license portability. I'm going to quote from this. Although for some professional licensing can serve as a beneficial role in protecting the health and safety of public, it generally limits the number of workers who can provide certain services. This reduction in the labor supply erects many barriers in labor markets, which can restrain competition, potentially resulting in higher prices and reduce access to services. For occupations that generally require state licensing as a public protection measure, FTC staff encourages stakeholders such as licensees, professional organizations, organizations of state licensing boards, and state legislatures to take steps to improve license portability. Fearing that the feds would take legal matters into their own hands, NABP and certain boards of pharmacy are actively discussing this topic. In response, Vermont is now the second state that does not require a law test. Michigan allows Canadian pharmacists to practice in their state. Idaho is now statutorily allowed to enter into a pharmacist licensing compact similar to a very successful national nursing compact. As states race to improve license portability, especially with lessons learned during the pandemic, California is behind the national trend, hitching their wagon to an older way of thinking, proposing to require non-resident PICs to obtain full-blown California licensure. This includes passing California's jurisprudence exam, which is arguably the most stringent jurisprudence exam in the nation. Currently, 19 states mandate some sort of non-resident PIC. As you can imagine, finding a pharmacist who holds all of these licenses is extremely challenging and may very well lead to disruptions in service to the citizens of California. CVS Health suggests that the committee not approve of the draft language and instead contact the FTC and NABP to discuss their vision of future non-resident practice and licensure. If California believes that some level of assurance is needed, states have addressed this differently, such as an attestation statement within the licensing application, or in the case of Iowa in your meeting packet, a registration that includes a specific training module for non-resident PICs, falling short of the barrier of care that full-blown California licensure would create. Thank you for your consideration.
Thank you for the comment, Mark. Okay.
This is the moderator.
I think there's one more, Dr. Gray.
Yes. Let me send a request to unmute Stephen Gray. Give me just a moment. Request has been sent.
Thank you again for the opportunity to comment. I would like to just ask that you give serious consideration to what Mark Johnston said. Our experience has been in looking at what has happened in other states is there is quite a possibility if there is one person who is truly the pharmacist in charge of an out-of-state, a non-resident pharmacy, and something happens and that person is no longer available. So really what happens is you're not requiring one person per non-resident pharmacy to be licensed in California. You're requiring, in some cases, a half a dozen or more persons to be licensed in California that don't work in California, just in case something happens to the one person. They quit, they die, they get sick, they get whatever, and they can no longer serve in that capacity. So the burden can often be quite substantial on this and will add to the cost and add to some potential problems. The other thing I'd like to point out, there was a suggestion, I think it was well intended, that instead of a license, it may be a registration. I would just point out that under the current statute, Business and Professions Code 4032, the term license and registration are synonymous terms under California law. And so you would need to address that if you're going to go with the concept of registration, which means that they're just identified in case there's an issue versus actually getting a license in California. And so those are my comments. Thank you.
Thank you for the comments, Dr. Gray.
Next individual, Lori Walsomley. I apologize, I've mispronounced your last name there. I'm going to send a request to unmute your microphone in just a moment. Request has been sent.
Thank you, moderator. Board members, can you hear me okay?
Yes, we can. Thank you.
Thank you for the opportunity to make comments today. Lori Walmsley on behalf of Walgreens. Again, I would like to echo the comments of my colleagues. While the focus here is really probably large mail order pharmacies, I just want to call to attention that there are a number of other smaller pharmacies that could be impacted by this as well. We have a number of pharmacies that provide specialty medications that are licensed as California non-resident pharmacies that provide limited distribution drugs based on the network that may not have very many pharmacists that work in these locations. This full-blown requirement to require full licensure would be a detriment, especially to some of those smaller pharmacies that are within our network and could potentially reduce patient access for Californians. So I would just like to echo the thought of let's consider other alternatives to achieve your goal rather than full-blown licensure. Thank you.
This is the moderator. I do have.
Thank you for the
a hand that
comment.
is up.
All right. Thank you so much. Thank you for all the public comments, everyone.
Sorry, this is the moderator. Are you able to hear me?
Oh, there's actually Dr. Hopkins, I think, raised hand. So just want to make sure.
Yes. Can you hear me,
Yes, we can.
Chairperson?
Yes,
This is the moderator. Can you hear me?
we can hear you.
Oh, awesome. Thank you. I wasn't hearing no response. Yes, I will send a request to unmute Clint Hopkins. Request has been sent.
Hi, thank you. I would just like to speak in support of having full-blown licensure for pharmacists that are sending prescriptions to residents of California. Having previously been licensed in other states, I was actually licensed in 17 states. It is possible for a pharmacist working in other states and shipping medications into this state to be licensed in this state. And I think it's very important that any pharmacist who is providing services to residents of California is aware of the laws and regulations in California. And having a pharmacist in charge at that pharmacy will ensure that there is someone to be held accountable. And I think that it's very important and that we should do that. Thank you.
Thank you, Dr. Hopkins.
Moderator, no further. This is the moderator. There are no further requests. Would you like me to close the Q&A feature?
Yes, please. Thank you so much. Okay, with a motion and second and public comment, we're going to go for a vote unless members have any comments. All right, Trevor.
Yes.
Thank you, Jesse.
Yes.
Jason, I'm going to call upon you.
Abstain.
Thank you, Jason, and I vote yes. The motion passes. We'll have more opportunity to discuss on this topic at further board meetings. So moving on to next agenda item 9, discussion and consideration and possible action. And hopefully I will go through this quickly and then we'll take a lunch break and then we'll be back. Agenda item 9, discussion and consideration and possible action on continuing education requirements for pharmacists and pharmacy technicians, including development of regulation language to facilitate implementation of recently enacted legislation. Members, the meeting materials include relevant sections of law and background on this issue. You may recall that this issue was referred to our committee to develop regulations following discussion by the Enforcement and Compounding Committee about implementation-related activities surrounding implementation of recently enacted Assembly Bill 2194. Included in the attachment 6 is draft regulation language to establish the continuing education requirements for cultural competency as required by the legislation. I'd like to highlight that in addition, the provisions related to pharmacists also include consolidation of various CE continuing education requirements for pharmacists that are currently included in various provisions of statute and regulation. In addition, the proposed language establishes new regulations defining the continuing education requirements for pharmacy technicians that mirror the process used for pharmacist renewal. As I open up for discussion, I would appreciate both your comments on the language as well as would entertain a motion if you believe such action is appropriate. I note that a possible motion is included in the meeting materials and displayed on the slide. Members, any comments? And or anyone would like to make a motion? Jesse, go ahead.
Hey, Sung. I do want to comment that I'm very grateful we're consolidating all the CE requirements for some patient care services. I will say that as the language stands for cultural competency, it sounds as though a pharmacist can complete 1 hour of any cultural competency course, and it's my understanding that it's supposed to be specific to LGBTQ plus and intersectionality. So I'm just wondering if there needs to be clarification on the type of cultural competency course in the language.
I'm going to defer that to Anne and Eileen.
So Jesse, I'm going to jump in. I think that the language is okay. We did have it vetted through the DCA regulations unit, but we can flag that and ask them to look at it one more time and report back at the board meeting if that's okay. I apologize for the frog in my throat. Sorry about that.
No, that's okay. Yeah, that would be great. I just think too, if a pharmacist is looking through, the language and trying to figure out what cultural competency course they need to renew their license, they may just think anyone is acceptable since many states now require cultural competency just generally. So it may be good to clarify, but if there aren't any comments, I will make the motion to move forward with the language and then allow Anne to make any changes as she needs to when consulting DCA.
Sounds good. Thank you. Anyone
Second it, Sung.
Thank you,
It's
Jason. All right, with a motion and second, and we will open up for public comment.
This is the moderator. The Q&A is now open. Instructions will be on the screen shortly. If you would like to participate and you're logged in, press the question mark inside of the square, type comment in the text field and send it to all panelists. If you're calling in, press *3 to raise your virtual hand. I do have individual identified as Maria Lopez. Maria, I'm going to send a request to unmute your microphone in just a moment. Request has been sent.
Hi, I just want to make a comment about the cultural competency. I think that leaving it more broad is better. As presented earlier on the HIV impact and high priorities of Black and Latino ethnic or racial cultural competency is also needed, very, very much needed. And for pharmacists, the census data from 2014 to 2018, which is the most recent census data that the census has for employment, lists that pharmacists in California, only 2.6% are Hispanic or Latino, considering that the population in California is 38% Latino. We have a huge disparity need. And so we have a big discordance in cultural competency because very, very few pharmacists in California are Hispanic or Latino. And I want to point out that for Black African American, it's 1.6% of pharmacists in California are are African American. So I think that having broader language for LGBTQ plus and also racial, ethnic is very important. Thank you.
Thank you for the comments.
No further requests. Would you like me to close the Q&A feature?
Yes, please. Thank you. With a motion and second and public comment, we'll go for a vote. Jesse, Trevor, how do you vote?
Yes.
Thank you, Jesse.
Yes.
Thank you, Jason.
Yes.
Thank you, and I vote yes, the motion passes. We have one more item. I'm just going to push through this one as I think we might have a little issue with quorum after lunch. So we're going to move to discussion and consideration of Business and Professions Code Section 4111. In July of last year, the committee considered the issue of ownership prohibitions specifically related to prescriber ownership, including a prohibition by a person who shares a community or other financial interest with the prescriber. At that time, the committee considered proposed language that could be used to create flexibility for such ownership while maintaining the legislative intent of the prohibition. The meeting materials provide significant background on the issue, so I do not intend to review the information, except to highlight at the time of our discussion in response to public comment, the committee determined that additional consideration of other forms of ownership prohibitions should be considered related to pharmacist ownership. Attachment 7 includes possible language that could be used to expand provisions to allow a pharmacist that is authorized to issue a drug order under specified conditions to also own a pharmacy. As I open this up for discussion, I note that a change in the statute would be necessary to implement such a change. Members, do you have any comments on the language? I would also entertain a motion if you believe such action is appropriate.
Song, I'll make the motion.
Thank you. Trevor, sorry, we're kind of stuck with you. If you are okay, I mean, I guess.
Second.
Thank you. Thank you, Trevor, not to pressure anyone to doing anything they don't want to do. With that, any other comments?
Sorry, may I just confirm that it's the motion as displayed on the slide?
Yes, thank you, Anne.
Thank you. Thank you. All right. With that, we're gonna go for public comment.
This is the moderator. The Q&A is open. Instructions are on the screen. If you would like to participate, click the question mark, type comment, send it to all panelists. Or if you're calling in, press star 3 to raise your hand. No requests have been submitted. Would you like me to close the Q&A feature?
Yes, please. Thank you, Elizabeth. With a motion, a second, and public comment, we'll go for a vote. Trevor?
Yes.
Thank you, Jesse.
Yes.
Thank you, Jason.
Abstain.
Thank you, Jason. And I vote yes. I think for the purpose of quorum, just to make sure that it's clearly in the record that Jason is abstaining, but he's still here for the purposes of quorum. So Eileen, please confirm that that's okay for this motion to pass.
Yes, that's correct, because our understanding, Member Weiss doesn't have a conflict as defined under California law that would necessitate his recusal. He does it out of a sense of potential conflict with his job, but there's no actual conflict.
Yes, he's abstaining, not recusing. Just wanting to clarify. All right. With that, we'll take a lunch break. I'm thinking at least about 45 minutes. So hopefully we'll be back at 12:45 if that's okay. 12:45. We may not see Jason after, so if we don't, just in case, goodbye, Jason.
Bye, guys.
And we'll see you all. See you in about an hour, about 45 minutes. Bye, guys. Don't disconnect though.